So ESMO 21 had significant data presented in melanoma, and I urge everyone to go back and look at this data. Obviously, we've discussed, and you'll hear a lot about Keynote 716, which was adjuvant Pembrolizumab for high-risk stage 2 melanoma, showing a recurrence-free survival and benefits in distant recurrence. Also, ESMO 21 had an update on Relativity 47, which was Relatlimab and Nivolumab versus Nivolumab in previously untreated metastatic or unresectable melanoma. And this is the first combination to show progression-free survival benefit in a randomized fashion. So 10 months versus 4 months, basically, in treated populations. And this will become a standard in metastatic melanoma. Relativity 47 will have more data upcoming, but at ESMO, we showed that PFS across pre-specified subgroups and stratification factors favored this combination over Nivolumab alone. And then the idea of PFS2, that is, that Relatlimab and Nivolumab reduce the risk of progression after next line of systemic therapy per investigator assessment, or death versus Nivo alone. So being treated with this drug did benefit you more than just the time that you were on therapy. We look forward to further data from Relativity 47, including response rates and overall survival data that has not been presented yet. Jeff Weber presented data of tocilizumab with flip-dose Ipilimumab and Nivolumab, indicating a regimen that possibly could give you a improved response rate with a decreased incidence of toxicity. And that combination is going to accrue about 65 patients and will be updated shortly. But what we saw was a response rate of 58% and a clinical benefit rate of 75% with a low rate of grade 3 or 4 toxicity of 17%. And so that's almost half what we saw in Checkmate 511. So we'll see more from there. Dr. Weber also indicated some early data about serum cytokines at baseline versus week 7 that can give us an idea of toxicity and response. And TNF alpha increases were associated with toxicity, and IL-8 increases were associated with lack of response. SECOMBIT was updated at this ESMO, and that's Paulo Ascierto's trial, looking at what is the best way to begin therapy in BRAF-mutated patients, or 3 arms that were initially BRAF-targeted agents until progression, then immunotherapy, versus immunotherapy until progression, then BRAF, versus a short course of BRAF therapy, and then onto immunotherapy combination until progression. And what that trial showed was clearly, this phase 2 trial showed survival advantage in beginning with an immunotherapy. So this is the first time a randomized trial has shown that evidence. Christian Blanc presented some early data in relation to combination neoadjuvant therapy. And I bring that up because the neoadjuvant paradigm is going to be looked at in multiple trials, indicating for us a way to get better biomarkers for response that we can utilize in the metastatic setting, and understanding the role of response, pathological response, and pathological complete response in that setting, and the ability to decrease treatment intensity. Now, all of this data is important because these are not just trials for melanoma, but these are trials that can help set standards in other solid tumors where immunotherapy is important. And that list is increasing day by day.